Good morning. So we'll be starting the webinar in just 1 minute. Good morning all. I welcome you all to a webinar on dental practice in the era of COVID-19 and a novel approach, organized by Asia Pacific Association of Dental and Oral Health and a scientific partner, BioLeagues Worldwide, and a research partner, United Inverters. About organizers, Asia Pacific Association of Dental and Oral Health is one of the leading platform associations committed to improve dental and oral health by promoting advanced in science-based evidence through our initiatives in education and research. Oral and general health are related and are a key integrates of overall health and well-being and a quality of life. Dental carries paradental gum diseases, tooth loss, oral cancer, and oral manifestations of multiple illnesses. Oral dental trauma, noma, and birth defects such as cleft lip and palate are among the diseases and are conditional covered. The leading non-communicable diseases share modified risk factors with most oral diseases and conditions such as cardiovascular diseases, cancer, and chronic respiratory diseases. Tobacco use, alcohol intake, and unhealthy diet rich in free sugars are among the risk factors of all. About scientific partner. BioLeagues Worldwide is a non-profitable professional association which prominently promotes research and development. We at BioLeagues have brought a revolution in the field of BioLeagues Worldwide conferences. BioLeagues Worldwide conferences bring together the professional wizards and leaders who are explored all the avenues and reforms in the field of life science and medicine technology. BioLeagues Worldwide conducts events worldwide, which helps in enhancing the skills set of people from desired industries and also the form of common platform for eminent professionalities, physicians, research, doctors, researchers, academicians, professional business figures, and much more. BioLeagues conferences encourages better comprehensions about improvements and progressions overall worldwide through conferences with the speed of science and technology. We work with our motto of creating a better tomorrow by organizing conferences and creating a network which will help to grow a better tomorrow with the help of advanced technology and achieve sustainable development. So now I would welcome our speaker, Dr. Shikhar Jaiswal, who is a professor at Swami Vivekananda Subhrati University, India. Good morning, ma'am.
Very good morning. Shall I, am I audible?
Yes, ma'am, you are audible.
Okay, so I'm now sharing the screen. Is my screen visible? Is my screen visible? Is my screen visible?
Yes, ma'am, it is visible.
Should I start now?
Yes, ma'am, you can start.
Okay. So mornings are usually associated with warmth, fresh energy, and possibilities. And it is the possibilities which we are going to talk about today. So very good morning to all of you. Well, mankind has always been facing situations of crisis, whether it is in the form of earthquake or the Asian tsunamis or the man-made disasters like the Hiroshima-Nagasaki atomic bombing. So the figures which you see over here are the figures of the patients or the people who have lost their lives in these crises or the situation or these disasters. Then there was World War I, in which approximately 22 million people they lost their lives. However, to top it all, this was the pandemic of 1918, the Spanish influenza, in which 50 million people lost their lives. Well, why I'm discussing these stats are to show that how dreadful or how dangerous a pandemic can be. And actually, I do not need to tell you, because we are unfortunate enough to have been witnessing one of them. So declared a pandemic on March 11, 2020 by WHO, COVID has been a major health deterrent. It has led to the collapse of the entire health sector, disrupted our regular lives. Even it has caused the slowing down of the economy, an economic crisis which has not been seen in many decades. It has led to recession, unemployment. Massive lockdowns have been imposed, which have led to slowing of the manufacturing goods, disruption of the supplies, and many losses in the international and the national businesses, poor cash flow in the market. So many businesses, they were closed down and they were affected. And just like any other occupation, dentistry was also majorly hit. So because of the fear amongst the people and because of lockdown, there was so much decline in the OPD, empty patient chairs, and so much speculations, questions around the dental practice as such. How do you take care of the employees? Would you be able to practice dentistry in the way normally? So the effect of COVID-19 on the routine general dental practice was massive. And the people thought that practicing or dentistry, or the dentists thought that practicing dentistry in the COVID was not safe. And there were many challenges actually which we faced, like practicing dentistry without getting self-infected or without infecting the patient or infecting the family. And then there was this problem of revenue generation that was big. Why? Because so much stringent infection control measures were there, and they all need an investment. And ultimately what happened is the treatment cost increased and the people did not have money to actually pay for the dental treatment. So this was a big issue. And then there was doubt on dentistry as a profession, as a career also. So if you see that this is the admission list of NEET undergraduate examination 2020. And if you see this chart, this chart is actually of the colleges of Uttar Pradesh in India. And they show how many seats were vacant. Approximately 50, even 70% of the seats were vacant in colleges, even in the second mop-up round also, and this is 2020. Except for few colleges like maybe KGMC or Subharti, most of the colleges had vacant seats, and the people were not opting dentistry as a profession. That was also in the minds of not only the dentists but also the people, they thought that the future of dentistry was doomed. Well, New York Times on 15th March in 2020 wrote an article and said that dentists are the #1 professionals who face the greatest coronavirus risk. Well, this is another story that actually the COVID rate among dentists was approximately 2.54%, and this was according to an article by Araujo et al., which was published in 2021. However, this rate is before the second wave of COVID. But anyways, it does deserve some sort of pat on the back. Maybe that so much fear was there that we are working so much in proximity to the patient. So the dentists are very careful and they followed stringent infection control measures, and that's why they were not so infected. Well, while the entire world was dealing with the COVID they were dealing with the economic crisis, Amazon was launching new business ideas. It launched its virtual tours and experience platform on Amazon Explore. Then there were creative minds who had started startups were there at the time of COVID. The AI solutions for researchers and scientists, COVID-19 trackers, so many apps for online learning and entertainment, so many other things. And did you really know that these WhatsApp and Intrezi, all these innovative startups, they emerged during some sort of crisis? So my idea of discussing this is that if you go by the saying of Winston Churchill, he says, never let a good crisis go waste. And what is actually meant by that is that you have to take the crisis as an opportunity to do things which you could not have done before. So today I would not be talking about COVID as a disease, The information overload is there on the internet. So many seminars, webinars have been conducted on it. Today, I will be talking about COVID as a crisis and what opportunity did we as dentists have in this period of adversity. Well, COVID gave the dentists an opportunity to upgrade and reform their dental practices and reintroduce the best practices. Just for example, teledentistry, that became the need of the hour. The dentists, they also adopted a more digital prosthetic workflow. They resorted to digital impressions because of the issue of infection control. Similarly, you had to reduce the number of appointments of the patient. For example, a patient is coming today. You do not know in the next appointment whether he will be symptomatic or asymptomatic. So you wanted to finish the procedure fast without the physical presence of the, of the patient. So you upgraded, the dentists, they upgraded themselves. The single visits, they got trending, but to perform them, you needed armamentarium and knowledge and skills. So the dentists, they upgraded themselves with the armamentarium like apex locators. In India, still many clinics do not use digital radiographs, and this was the push which they needed. So introduce RVG and digital radiography. Similarly, clinics need to be redesigned for better infection control and better ventilation. Standardization of operating techniques was needed. It was mandatory by the DCI and by many other the regulatory authorities, and you had to reintroduce the best practices like rubber dam. Similarly, the dentists throughout the world, they adopted a more holistic approach towards practicing dentistry. Why? Because systemic health always was an integral part, but of course it took an upper hand and it became very important. Similarly, emphasis on history taking was there. So many webinars and so many online conferences were conducted throughout these 1.5 years. You see that these are the list of the webinars conducted by DCI, and see the number of registrations: 13,000, 20,000, 16,000. I mean, the dentists, they use this opportunity to upgrade the knowledge and their skills and to diversify career opportunities, how we're going to see later. And then, of course, they realize the social responsibilities that helped in developing better relationship with the patients. Also, because of the issue of infection control, the clinics had to go cashless, and they had to offer more flexible financing options to the patient, like the option of insurance coverage, credit and debit cards. So it was convenient for the patient, and it sort of helped in disciplining the budget of the dental clinic. Also, you had to go digital. There was no option. Why? Because you had to make sure the walk-in OPDs, they were no more there. So you had to call the patient beforehand, or the patient had to pre-book the appointments and tell about the symptoms or their history. And the appointments need to be reconfirmed or scheduled, and sometimes cancellation was there. So all this could not be handled without going digitally. So the dentists, they did create their websites, and they went digital. What happened was that in this, process of going digital, they automatically promoted and marketed the dental practice, which in the long run is going to be really helpful for them. So let's talk about this in a little more detail. So many changes were introduced about the oral health policies and guidelines by the government of India, by the DCI and the regulatory authorities, during this pandemic. And the clinics, the clinicians, they had to redesign the dental workspace so as to improve the ventilation. Then there was this issue of aerosol generation in dentistry. They had to limit it, and actually when in the dental practice, these are actually the bioaerosols, which are loaded with bacteria, fungus, virus, and they have the potential to float in considerable amount of time and inhale by the dentist or the other patients. So the risk of cross-contamination is very much. And the best way to limit bioaerosols in operative procedures is to use rubber dam. That's the most important thing. So there were studies which have been published and which show that the microbial content of these aerosols decreases by as much as 98%, and the risk of cross-infection reduces in the dental practice. So many webinars and online training programs were held to help the clinicians use rubber dam. See, rubber dam had always been there as a standard of practice, but the thing is, how much were you actually using them? So now, in difficult situations, when it is difficult to apply them, we usually leave away. So now the dentists got themselves trained for advanced rubber dam applications and isolations. And ironically, it is not just the infection control. There's so much literature which says that rubber dam also increases the survival time of dental restorations and increases the longevity of your restorations. And it's not that it's the first time the dentists are being affected by any airborne disease. I mean, there's tuberculosis, aspergillosis. But if you see this survey, which was held in central Italy, it says that 56%, more than 56% of dentists were not using rubber dam before the coronavirus emergency. So at least this is what COVID did. It brought this best practice, this best practice earned its place back. And the dentist started using it more. And definitely in the long run, it's going to be really helpful. Then also the dentist had to explore other means of reducing aerosols, like practicing drill-free dentistry. So the LSTR, use of lasers, ART, all this was encouraged, and all this was learned, and the skills of using these instruments and devices, they were earned by the dentist, or they sort of upgraded themselves for it. And definitely, whether it is COVID or non-COVID, there are a variety of clinical situations where you need to use them, and now they'll be able to apply them more properly. Also, upgradation of armamentarium, like these handpieces, which aorta handpieces, which have anti-suckback mechanisms. They have anti-retraction valves, which help to prevent cross contamination. They also had been very helpful in limiting the bioaerosols. Now, when during tooth preparation, also a lot of aerosol is created, so it is recommended to do it on a rubber dam. But the main thing is about the manual impressions. Now, these manual impressions, there was this risk of infection by these manual impressions, so they had to be dipped into, they had to be disinfected. But apart from that, when you take manual impressions, the risk of gagging and coughing by the patient is always there, and hence the risk of infection is always there. So the dentists, they resorted to digital impression and computer design, even 3D printing. And the benefit was twofold. Like, it was also more comfortable with less chairside time and more accurate. Apart from that, when you resort to 3D printing, it reduces the errors which is caused because of the manual modeling, which is there in the labs. So you get more accurate prosthesis. So to handle pandemics or to handle COVID in dentistry, the dentist resorted to a more digital prosthetic workflow, where digital impressions were taken, virtual face bow and bite record registration, guarded implant placement. So all this was done. So those who knew it followed it, and those who did not know it tried to hone their skills for it. Now, so again, upgrading themselves and the clinic also. So apart from the infection control thing, these, as I discussed, have also helped in delivering more precise restorations to the patient, which requires less chairside time, less adjustment, and of course, more patient satisfaction. So all in all, it's a win-win situation for both the patient as well as the dentist. There are many blogs which have been written by dentists, and they show that how these modern technological innovations, they help the dental care providers steer through the coronavirus pandemic. The dentists throughout the world started to approach the dental problems in a more holistic manner, whether it were the isolated cases of patient with issues of teeth grinding, which were related to the COVID related stress, or a clear correlation was seen between oral and systemic health. So you see that this was a study which was published in the British Dental Journal, and it said that poor oral hygiene or poor health status affected the severity of COVID-19. That means the patients who had poor oral hygiene had hyperinflammatory response when they suffered with COVID, and the recovery period was delayed. So this fact was, of course, taken it and understood more by the patients as well as the dentist. So the approach of looking at the patient as a whole and not just focusing on the oral cavity by the dentist, this approach, it resurfaced, and even the patients realized this. There were so many talks on the television shows, so much information overload on the mobiles and the other online platforms, and it was easier for the dentist also to educate the patients regarding this. Then there was oral mucormycosis. It was seen that poor oral hygiene as well as poor immunity was related to the occurrence of oral mucormycosis in the patients, in the COVID patients. So the dentist took this opportunity to educate the patient regarding the relevance and importance of oral hygiene and how it impacts the systemic health. And they could tell about the measures of maintaining oral hygiene. Now, the habits which were inculcated during this period, whether it was about the sanitization, disinfection, hand hygiene, or the dental hygiene, these are going to be etched in the memories of the patients, and this is for the lifetime. definitely helping everyone in the long run. The most important change actually which took place was the providing virtual care to the patients and adopting teledentistry. Well, this was not very popular in India, and it is basically the involves the exchange of clinical information images over remote distances for dental consultation and treatment planning. And AD, as early as in April 2020, disseminated guidelines upon the billing and coding of teledentist visits so that they can so as to use a facilitate or use to facilitate the use of teledentistry during the pandemic. Also, a union ministry had also given guidelines for the teleconsultation. Now, again, as I discussed, this was not so much practice in India, so this was new for the patients and for some of the dentists also, except for maybe in the metro cities, it was not being practiced so often. So this happened somewhere in April 2020, and after that, you see this word teledentistry got a lot of Google search. And this is a report which is published in USA and says that telehealth services are going to see an explosion of 830%. And even in India also, the patients have now started to accept it, and they like it. Why? Because of the reduced travel time, more accessibility of the specialist almost within a few minutes. So it's good for them, and they're realizing its importance. For the dentist, it also has an interprofessional network. What is meant by that is just for example, a patient who has got some symptoms of COVID also needs a dental treatment. So rather than the patient talking to the dentist talking to the medical personnel, and then so much confusion, it is better to do maybe a real-time consultation with the dentist, the medical personnel, and the patient. All three can talk. The patient can ask the doubts, you can set a treatment plan, and then you can go ahead for it. So without actually meeting and without actually wasting time, you have come to a treatment protocol which needs to be done, and the patient is clear about it, the dentist is clear about it, and the medical personnel about it. So it becomes really easier. And if you think that it is telemedicine which is more helpful, because in that you don't have to actually work on the patient, and we always have this doubt in mind, isn't it, that dentistry you have to perform the procedures. How can it be performed telephonically? But you see, there are many when the disease is in the reversible stage, then you can manage it without actually the physical presence of the patient. Also, suppose your patient is going overseas and wants some consultation from you, then it is helpful. For remote monitoring of the patient, it is helpful. So like on the websites, you can create the questionnaire, and these questionnaires, they can have medical history. So before the patient actually comes to your clinic, you have a record of the medical history of the patient, about the concerns and the goals of the patient, what he's expecting from the treatment. You can guide the patient to upload the images and the videos so that you can see you can do the extraoral and the intraoral examination. So when you have all this data with you, the patient can evaluate the data. The patient can plan along, the dentist can evaluate the data, and the dentist along with the patient can plan the treatment accordingly. For example, one particular clinical situation can have you can have an option of veneers or crowns or whatever the treatment is. You can ask about, you can talk about the budget and the economical issues. And when you have decided upon a treatment plan, then you can book an appointment with the patient, and the patient can agree upon a particular type of treatment modality. So you know that before the patient comes to the clinic, you know that this would be the duration of the treatment. And maybe suppose I have to go for a retreatment, I have to go for a file retrieval, I know that it will take a lot of time. So possibly I will schedule the patient in the morning, and I will increase my appointment timings so that I can relax and rest a little bit in between. So all this can be managed very well if all this happens before the actual physical presence of the patient. One thing more very important, you can also pre-charge the patient. So you know that the patient is not going to cancel the visit. So that is also one important aspect. Apart from that, telemonitoring can be easily done. You can guide the patient upon the images, how the images have to be taken. So you, again, except for maybe the investigations like x-rays, if the only images are concerned, the patient can take the images, can send to you, and everybody can manage that. So the various forms of teledentistry, the two major forms, which is the synchronous and the asynchronous. Asynchronous is in which the patient stores the data, for example, the images, and forwards it to the dentist, and the dentist is going to see it and maybe answer at a later date. And real time is asynchronous, in which by video conferencing or by using some app, you're like what we are doing, like doing a Zoom meeting, the patient can directly contact with the dentist. Now, and there are certain mobile apps also which have been popular during these periods. Now, the most favored one is a real-time consultation, because this is when the patient can actually talk to the dentist. He can put forward his queries. They can talk about the treatment planning together. So this is the one which is the most often used. Okay, so now coming to another aspect, we've always been taught, especially in dentistry. Why? Because we have very close proximity to the patient. So we've always been taught, treat the patient, all the patients as infected unless and until proven. But how often do we actually follow it? But COVID-19 compelled us to. So the infection control. So this was a study which was done among the Iraqi dentists during the COVID-19 outbreak, and it showed that the awareness and the levels of precaution. I mean, the awareness about the infection control measures, it increased to as much as 94% among the dentists. So at one time we were not so careful about the infection control measures, but now we've become super careful. So the self-care became really important, because when you are infected, because it is the disease is very infectious. So when you are infected with the COVID virus, you can transmit it to your family, to your other patients. You have to be really careful. So the PP kits, the primary modes of infection, people started researching more about it. So whether it was PP kit, the type of mask, eye protection, or the secondary measures like vaccination. So there were so many videos and so many tutorials on the proper donning and doffing of PP kit and the type of masks which are there. So whether you should go for an FFP2 or you should go in for an FFP3. If the patient is COVID positive, you're going to go for maybe an FFP3 mask and an N99. What the difference between them? So all this knowledge was gained. So was gained, and the dentists, they were upgraded about it. Also, the infection control measures of the clinic, they got upgradation, like the use of high volume suction of the HEPA filters. These are the particulate air filters which can remove the submicron and the supermicron size also of the SARS-CoV-2, or maybe the hypochlorous generators which are there for fogging. So what happened was that because of this upgradation of these infection control measures, it was not that the dentist and the patient, they were protected against just COVID virus. Of course, there was fear of COVID, but the prevention of the other viral and bacterial diseases, like there's MERS, there's influenza, there is tuberculosis in India still there. So they also protected themselves with several other viruses and bacteria. So if you remember, during the period of COVID last year, when people were actually taking all the stringent measures, how many of us were actually catching colds, or the number of cases of influenza, they also decreased. Why? Because the precautionary measures, they increased. The clinics had also to go cashless. Being cashless is one of the infection control measures which we had discussed. And apart from that, many of the clinics also went paperless. So these are many dental practice management softwares. They were introduced, and the clinics utilized them. And by utilizing them, it was not that the issue of infection control was solved, but also it regularized and the whole clinic as well, like appointment scheduling, billing, clinical documentation, patient records. All of this got systemized and regularized in that front. Apart from that, there were few cancellations, because if you pre-charge the patient, the cancellations are lesser. So more accurate, patient charting system, more secured storage for the patient data. So all these things were an added advantage of utilizing these softwares. Well, it is said that necessity is the mother of invention. And when COVID era has been one which actually shows that, because I think maximum innovations in terms of shields or masks or PP kits have happened. So this is one of the face shields which was designed by one of the dental students along with this professor in the University of Colorado School of Dental Medicine. It was in March 2020, and it got patented later on. And then there were so many other innovations, the anti-COVID face shield mask and face shield, and then the mask. And these also served as good business ideas, and as the Prime Minister says, the Atmanirbhar Bharat. So the people actually delved into or focused on the research and the designing and the manufacturing of the PP kits, or more, or the measures like hypochlorous generators, which were needed, which was the need of the hour. Now India, it became from zero, it became actually the second largest manufacturer of the PP kits. So the idea is that you just cannot sulk about the situation. You have to see that what you can do about it. So that is important. Now, many of the dentists also enrolled themselves in the voluntary outreach programs because you needed a lot of workforce. So dentists enrolled themselves in these programs, and it was a life-changing experience for the dentists. I also have one of the students who had enrolled herself in COVID wards in Delhi, and the outlook of the life actually changed for her. It sort of increased the professional standards. It made you more compassionate towards the patient, and understanding of the social issues. All this increased. So basically, it shaped you as an individual and as a better dentist also. Also, the appreciation for alternative career path in public health was also seen or considered by many people who found it to be a good alternative. Well, this was also the opportunity to to realize that now the teaching methods are redundant. We need to innovate a teaching methodology, and we need to suit this different situations like remote learning. Novel intelligent technology has to be applied for future dental education. And what I mean is not just the e-learning platforms. Of course, these were used, like the pedagogical software tools and or the live streaming of videos, virtual meetings, social media. This sort of boomed in this whole period. But it is not just this. It is we need to explore the horizons. We need to broaden the horizons. We need to bring back the virtual. I mean, not bring back, to introduce the virtual reality training platforms. So this was in 2015 when Nobel Biocare held its first dental surgery via the virtual reality platform, allowed the observers to actually virtually assist and see the whole surgery and from the surgeon's perspective. Well, this was a picture which was posted on Facebook sometime back by one of my matchmates, and this was way early in 2000, peeking over the shoulders, trying to get a glimpse of what the teacher is saying, trying to say, and not understanding even a bit. So from there to here, we have to take the leap. We have to introduce new technologies. And then there are augmented reality programs, the augmented reality dental training simulators. And it's not that it is just in the air. So many, the dots that you see on the right side, these are the countries which are actually using these simulators. And what exactly are they? In the preclinical labs,
obviously cognitive skills too, understanding how to correct the preparations from the information they're given. The nice thing about it is it's the repetition part of this. I'm not having to stand there and for the students stand in line and wait for me to evaluate every tooth.
So what is happening is that when you are working on these simulators, you are able to see what you're doing in a three-dimensional image on the screen, which was shown in this video. So the student is able to see on the screen, he is able to see that how much depth he is going when he's preparing the cavity, how much width is there, how much depth is there. Immediate feedbacks are given that yes, this is where you're going wrong. So they don't have to stand in long queues and wait for the instructor to evaluate and tell them. So it decreases the load on the instructor also, and decreases it becomes better for the students also, because they're actually they can do the mental imagery thing. They can imagine that exactly what they are doing. So these would be really helpful in remote learning also, and without the physical presence of the operator as well. Apart from that, intelligent virtual training environment is necessary for dental surgery, because this gives sort of first-hand experience to the operator before he actually indulges into the patient. Now, one thing more is there that it also made us realize to reassess the way we are actually assessing the students. we had to resort to online assessments, and there were so many online examination softwares which are there. Of course, online assessments has its own pros and cons. The issue of cheating and everything is there, but then there are many softwares available in the market, and this reduces the administrative load. It is quicker to issue results. It makes the test more automated. It makes it more environment friendly, and not only that, I feel that it also is less biased, and it is more objective. So you're actually testing the actual knowledge of the child, and it is definitely, we can include it as a part of assessment systems. Last but not the least, just like everyone, the dentists, they also realize the value of health and family time, and took the opportunity to indulge in both of them. So in this COVID era, let's reflect, learn, and change. And let's take this opportunity to refigure the dental practice, to standardize our operating protocols, to adapt teledentistry, to go digital, to incorporate innovations, and to have a more holistic approach. And let's take the opportunity to restructure the dental education, to equip our dental graduates with better technological and scientific advancements, to teach more evidence-based dentistry, to train them for basic healthcare services so that they can be utilized in this national emergencies like COVID-19, and tell them the practical usage of dentistry. So no, I'm not going to say that let's take this opportunity to increase the treatment cost. What I'm going to say is that let's take this opportunity to provide better and safe treatment to the patient and then charge them for it. The treatment costs have increased during COVID times, and initially the patient, that was because of the stringent infection control measures and upgradation of the clinic which was needed. So definitely the treatment costs are going to increase. So initially the patients were skeptical about it, but just like everything else, it is a new normal. So everyone is okay with that. So yes, in every adversity, there is an opportunity. So it's just a matter of the way you see it, matter of how you perceive it. Thank you everyone for your patient listening. And I'm sure there's so many other things to be discussed. And my fellow speakers, I'm very sure that they're going to focus on these points.
Thank you, ma'am, for your wonderful and informative presentation. So if anyone is having any questions, then they can put their comments in the chat box. So I would like to welcome our next speaker, Dr. Bennete, Senior Lecturer, Faculty of Dentistry, SEGI University, Malaysia.
So is my screen visible? Am I audible?
Yes, sir, it's visible.
Okay, I'll just
Yes.
make it into full the slideshow. Yeah, is it now? It's fine. Everything is clear. Can I begin?
Yes, sir. Yes, sir.
Okay, so a warm good morning to all the participants for APADENTO's webinar CD program. And the topic I'm going to speak today is going to be dental practice in the era of COVID-19, a novel approach. And I bring warm greetings from SEGI University, Malaysia. Just give me a second because I have a video. I'm just going to stop sharing and then reshare. Just give me a second. Because I just need to share the sound, just which I didn't do. 1 second. Okay. Yeah. So this is where currently I'm working in SEGI University, and I would like to show you a small 1-minute video of my campus.
All the infection. Cleft.
Yes.
Bennete, sir, we can only listen the audio, but the video we are unable to view it.
Pardon me?
We can only listen the audio, but the video we are unable to see it.
Okay, 1 minute. Just reshare this.
Video is not shared.
Yeah, just reshare.
Yeah, sir, sure. Can you play it now?
Now?
Yes, sir, we can see it. Perfect.
So yes, we do have a swimming pool to cool ourselves. And recently we have been awarded the 5-star plus rating by the Quattrolacchi Simons ranking for universities, and which is there for 6 years. I mean, which is there for 3 years. So I have some small disclaimers. It is just for educational discourse and deliberation and not any liability to either the Faculty of Dentistry or SEGI University. And what I would like to encompass by this is I would like to talk about certain implications and recognize the COVID, identify what challenges we have had, just see what are some guidelines and risk assessment tools, and to compare and contrast. The previous presenter, Dr. Shika, has beautifully presented the topic and covered most of the important things. So it will just be a little bit of a brush up with focus on certain areas which haven't been covered. So this guy changed this COVID-19 or the coronavirus. How the term came about is because of this, the corona CO virus, the infection, the disease, and which came about late in 19 and shook the world, and it is still shaking the world. And when we talk about this dreaded C, is this video visible?
Khasi mama, ready? 1, 2.
Stay
Even though I'm perfectly fine, I feel like cover.
So yes, this corona has made us like this, and the fact remains that we, starting with C, we have also choices, chances, and changes, and one must make a choice to take a chance, or your life will never change. And this corona has taught us this. And a career is not just about earning an income; it's about pursuing the essence of your life. So when we are studying this dentistry, it's not just about the career, it's about our passion, it's about so much more. Uh, so this COVID-19, it led to a global healthcare crisis among the dental care workers were the most affected, and many reports have highlighted this infectious nature. And in 2020, as a response, many public health authorities, including the American Dental Association (WHO), called for postponing the elective dental procedures at the start of the pandemic. And that can have like a double-edged ripple effect, because now if you're going to be postponing, when you know that the oral health is linked to the systemic health, and we consider it around 57 systemic diseases to be associated, so it brings about spiral effect kind of a situation where we don't do the treatment and the load of the oral microorganisms is very high. So in spite of all these lockdowns and things like that, it was very difficult to protect the public health. And later on, as more and more studies, more and more research, the study which was published in JADA, they found that fewer than 1% of dentists were estimated to be COVID-19 positive. Hence, the ADA then decided that it's okay, we can start our dental care, but we do it with caution. We do it with the highest level of PPEs and using all the different masks which are available, the goggles, face sheets, HEPA filters, and all this. And to control the risk, ADA also recommended the use of rubber dams, high vacuum suctions, and all such things. Also, they resorted to hand scaling instead of ultrasonic scaling. Now, individuals in the dental care settings are exposed to three potential sources of contamination with COVID-19. So you have the close interpersonal contacts, less than 1 meter contact with saliva, and the aerosol generating dental procedures. Hence, a risk management model, which I'll be showing you, is proposed, which I got from a wonderful article, and which is current up to 2021, which helps about in the dental care settings how to implement the different strategies. So this is from Russia. It's a Skenov University COVID risk assessment criteria, what is called as RAC, which was a wonderful article by Oleg Mitrokin in 2021. So in which they talk about a high, medium, and low risk, and it is much better than the CDC model or even your WHO model or even the British Medical Association BMA model, because it encompasses many more things. And it talks about, based on this, you have the high risk where it is very easy based on the contact, the distance, the contact, how much time the patient has been. If it is more than 15 minutes, we know that is why we have that criteria kept in mind, and the lack of whether the person was wearing or it was absent. And the low risk is if it is not more than one contact, it was considered as a low risk, but depend upon the other factors which I also highlighted. And the medium risk is when the risk assessment criteria do not match the low risk conditions. So that's how we go about in this Shenos model, in which we talk about how we can go about. And they further, in that article only, they talked about the occupational classification system, which in the public health setting also, things which we do on a daily basis, like contact with patients, what kind of the instruments they wear, about the infected surfaces, about the fluids which are there. Hence, as the previous week also told, using rubber dams is very, very much of importance. And whether we are using the PPE, the right PPE. Also, nowadays many clinics are also incorporating HEPA filters, which have to be important, and also the ventilation to keep fresh air flowing into your operatory. And this is of paramount importance, especially if you do not have a window or things like that, to keep the door of your clinic open so that the air continuously circulates. So some suggested recommendations. So first is we talk about is the implementing teledentistry. And so the first consultation should start. So either it starts by your receptionist, or you would have to do it. If you do not have a receptionist, you need to train about these additional roles which they would have to play. A questionnaire survey where they talk about since how long, if you're having, are you febrile, having fever, what's your temperature, are you in contact, and all these kind of questionnaires which need to be taken. And this telemonitoring, and this is the primary teletriage which needs to be done, and find out what kind of thing. So the patient will say, no, my gums are bleeding. So you know that you would have to do an aerosol generating AGP procedure. So things like that will help you to schedule your patients also correctly. So probably if it's an AGP procedure, maybe towards the later part of the afternoon, where then later on you can sanitize properly before you start off your clinic later on in the evening. So things like that. Next is the waiting area, because they found that it is transmitted to respiratory droplets. There was also the, in the initial stages about fomites, and people were crazy sanitizing each and everything. Other people were touching, but as far as possible, the decorative hangings, magazines, all these things were removed from the waiting area, and the area was kept bare as far as possible. Also maintaining the, I don't like to use the word social distancing. Let's use it as interpersonal distancing, about 2 meters, so that even if the person sneezes or coughs. And of course, the fact that the patient has to use masks, and now they say that better to use double masks to be safe, on the safer side. And the time also of dental procedures, it should be minimized in the waiting area. So all this you have to factor in when you're scheduling appointments and patients into your area. Also coming to the next, sorting patients. So all asymptomatic patients should be considered as people with COVID-19, and all dental procedures should be revised after you have identified. So if you are having, you would have to then later on, sanitize properly. If you treated one, see that the remaining appointments are scheduled in such a manner that you keep a proper time. Maybe you reschedule it for the next day and things like that. So coming to four-handed dentistry and dental ergonomics. So where you're going to be sitting is of paramount importance. So if you're a right-handed person, it would be better to sit at around 10 or 11 o'clock. And if you are a left-handed person, around 1 to 2 o'clock. So the position to avoid is 8 o'clock for a right-handed, and around 3 or 4 for the left-handed individual. So always practicing four-handed dentistry, otherwise you'll not be able to use. So not just to use the low vac suction, maybe that the patient will be having. You have to use a high vacuum suction also, okay? Especially if you're going to do any AGP procedures, especially if you're doing scaling and things like that. Next comes to the important topic of pre-procedural mouth rinse. So there have been a lot of studies for and against the same. Okay, so even here we follow using a pre-procedural mouth rinse. Actually, this is like a standard norm. Now, different solutions can be used. I will tell you in a minute. But the important thing is the time, that it is undiluted. And the other thing is for how, whether the patient is gargling it in the right way. It is not the fact that you just take some solution in the cap and you just, the quantity, and just put it in your mouth just for, 10, 15 seconds and just spit it. So it has to be done very systematically. So I would suggest that chlorhexidine, there is a mix of studies on that too. Now, the fact about chlorhexidine is the studies which said that it didn't work used a very low concentration. Now, the concentration in our mouth rinses is much, much higher, at least 3 times higher. Okay, so we are using concentrations of 0.12%. In such a situation, you need to use it 15 ml of the solution. Or if you're using 0.2%, you need to use 10 ml. Please do not dilute or mix it with water. Okay, so that is of importance. Then you need to rinse for at least 60 seconds, okay, for a minute. In that, you can have 30 to 40 seconds, you can rinse normally in your oral cavity, and also a throat gargle. Like, you do a salt water warm saline rinse in the throat when you're having a sore throat kind of a situation. Now, why this is because of the fact that uh, it has been found that there is a high content of the virus in the superior respiratory tract and in the nasal cavity and things like that. So, and to decrease the load of this, it is very important that you do this. Now, the beauty of chlorhexidine is that it has substantivity, and they have found that it reduces for up to 2 hours. And also, since if it's a case of periodontal disease and things like that, chlorhexidine will help to decrease the other load of the bacteria. So that also is beneficial. Now, when you're coming to the other products which have been suggested, like the hydrogen peroxide, 1% has been suggested also, or povidone iodine also has been suggested. CPC, cetylperidium chloride, this also has been suggested. Now, the ml of each has to be considered. So at least 10 to 15 ml, okay, of the solution, and if CPC, at least 20 ml of the solution you need to use. Okay, do not dilute it, then only it is efficacious. And the time. So many a times when you say that it doesn't work, you have to analyze and observe how the patient is gargling. Point number one. Point number two, which is of more importance, is how the patient is going to spit it and where he's spitting it. If you're making him spit in the near the dental chair, in the spittoon, okay, so see that he does it gently and not just spatters. He bends his this thing, or you get it done prior. You have a wash basin, you get it done prior, and he does it supervised, not he uses the restroom and then he's gargling and then makes a mess in that area. So that is very important. So which again, training needs to be given to your receptionist in this. So this is of paramount importance when you're doing it. It's not the fact that you can just do it haphazardly. Okay, if you want it, your pre-procedural rinse to work. So these are the 4 rinses. I definitely recommend chlorhexidine, and then you can use povidone iodine. So some people may have betadine allergies and things like that. So in that scenario, you would want to avoid using, especially in thyroid patients. This cannot be overemphasized. Many people have now learned about using rubber dams. This brings a lot of difference. Also in your quality of work, it might take a little more time for doing the procedures because you would have to learn this. But there are numerous courses, as Dr. Shika has beautifully told also, and a lot of online courses, a lot of hands-on courses where you can learn how to do a quick 5-minute rubber dam. And rubber dam isolation is of paramount importance. So continuing education courses have been there. You need to update yourself. Okay, because the knowledge is constantly evolving and changing. Guidelines are changing. Okay, so we cannot keep on saying that in the beginning it was like that, in the beginning this was like this. So you have to constantly see what is latest. What are the updates in 2021? That you have to update yourself. And are there any extra measures which need to be taken? Something on the mask. Is double masking the norm now? So things like that you have to consider when you are doing and update your knowledge. So there are a lot of online forums, a lot of online, and this is one example of the same. Next comes to the COVID-19 vaccination. Yes, we are vaccinated. So many places like Malaysia too, as of today, it seems that there are 96% people of adults who have been vaccinated. So we have to motivate from our side also the fact to the patient to get the vaccination done. So in India, we have the Covaxin or Covishield, any one vaccine. So even after vaccine, you might get, the patient may argue. Very true. So for such patients, you need to tell, even after servicing your vehicles, after servicing, doing the thing, the car, you still needs, right, the service next time, or, it's a life process, right, which continues. Same way, the fact that you've taken the vaccine is not like it will, eliminate or no chance, or you become like God, that you will not get COVID-19, but rather the fact that if you get it, the disease will be very mild. Okay, because your body has already been conditioned for the same. Okay, so you as a dental practitioner also need to follow this, and this also you can do it when you're doing your teletriaging, when you're doing, have you taken both the doses and things like that. If not, keep at least a 14-day period after the second dose and things like that to improve the chances to be on the safer side. Okay, so even the dental care workers, when you're speaking about that, you should be concerned about your receptionist, your technician, anybody, the cleaner who's coming, all these people also who come into your dental operatory, come to your dental clinic, they also need to be vaccinated. Yeah. Okay. So here, for example, in our university, at the gate, even before entering the premises, the guard will see whether you are vaccinated. If you are not vaccinated, you have to do an about turn. Okay. So only such patients are permitted in. In spite of that, we have very recently we had a positive case. So because we go back home, we go here and there, we go to the malls, we go to this. So what do we do in such situations? Yes. So we closed down the clinic, we sanitized everything, and then after a gap of 1 or 2 days, yes, it causes revenue loss because you would have had certain scheduled patients, but this has to be factored in. So that is why all this you have to consider prior to you getting the patient in for this. But these are we cannot let our guard down. Okay. Coming to the other recommendations. So like positioning the dental handpiece correctly, don't attend your mobile phones and things like that. You wrap the mobile phone properly. Don't be in that working area. You can use a clean wrap, So using the dental water lines, flushing, rinsing. So all this has to be. Otherwise also it has to be done, right? So now in this era of COVID, just like how in the beginning, before AIDS and HIV, you just use our hands and do all the things. In many places they still do, but most of the places they do not, right? Now, in the modern day, everybody uses gloves because of the HIV, which could be transmitted and things like that. There was a famous case in US where the dentist caused the transmission. Okay. So, and as a result of which the guidelines changed. Similarly, now the guidelines have changed. So now the PPE is mandatory. Okay. Covering, pre-procedural rinsing, using all these things has become mandatory. So you need to update yourselves too. Yeah. This all flows into a concept called as slow dentistry, which I would just like to highlight here. Now, what is this concept called slow dentistry? Is it like the turtle and the tortoise the tortoise slowly won the race, or the hare and tortoise story, which you would have heard? So this is a concept which was founded in 2015 in Switzerland by Dr. Miguel Stanley and Nina Blatter. So it got registered in 2010 and the European trademark was registered in 2015. So it started initially in a very grassroots movement level, and which got shared on globally. Now it is there all over the world. Okay. And because of the level of lectures and things like that, which were given by Dr. Miguel, where he talked about this concept. So it is based on four, so that's Dr. Miguel Stanley. So it is based on the four cornerstones, that is, effective anesthesia, using rubber dam, disinfecting the equipment. So you need to have a good autoclave, class B autoclave with the proper drying cycle and things like that. Okay, cannot just use any machine anyhow, things like that. Yeah, and using informed consent. So what he says that the shifting to a slower pace, it's, I've heard the proverb, slow and steady wins the race. This lessens the stress for the dental practitioners. So COVID-19 has made us, more pertinent to this fact. So these are the four cornerstones: the informed consent, which you need to take for the patient for every case, and document it. It should be in the patient's language so that he or she understands. Okay, pain-free, the IDA and so many other forums have beautiful ones where you can see and fine-tune it for your clinic. You can add some things. Pain-free in different languages too. Pain-free dentistry, giving time for the anesthesia to work. Proper disinfection protocols. Following the procedure, you need to have even the follow time before putting the patient of at least 20 to 30 minutes on the same chair if you are a single chair operatory, and the use of the rubber dam. So in the beginning, it was very slow, and from March 20, it just bombarded, and more than 55% people had taken this concept and accepted this concept, and they had become members. So it's a little steep, but it's worth encompassing if you want to become the leader in that area. You want to be the this. So Nina Blatter, she was the person because she had bad experience with the dentist. So she thought about this, where some of these things, these four cornerstones were missed out, and she had that's when they came together and they founded this non-profit foundation called as the Foundation for Excellence in Dentistry. So you can just Google it up and you can see if you want to become a member, you want to be part, you want to learn more about these concepts of slow dentistry, but you can be a part and parcel of them too, if you are very much interested. So coming more towards the end, so some certain slides, which are the procedures which can be this. So the routine elective were the ones where they said that it should be postponed in order only do some, very much where a lot of endo and pain and all this. So during the, which can also be done using the chemo mechanical caries removal under the rubber dam isolation or some oral surgical procedures. So even in the beginning, they said less and less usage of the high speed handpiece and more you use the slow speed and things like that and all. And in this scenario also you could use if you're having the lasers, because it's a fantastic tool. If you're having the hard tissue laser for cutting caries, that's also very good. Or you can use the soft tissue laser if you would like to do like a laser disinfection for the pockets and things like that before you would like to go ahead and do the scaling procedure. So even for oral and maxillofacial surgery, you can do about all these kind of situations. Then you have for the ortho and prosto, so if something is the wire is poking, you cannot say, you come later on, so you need to see that you correct all these things. Okay, so anything which causes gagging or coughing, very difficult, but there are ways where using acupressure points on your wrist, you can control the gagging, things like that, or the Mention point on the chin where you can help in controlling the gagging. So this in a nutshell will also tell you the measures. Okay, so this is from the latest 2021 articles. I have refrained from seeing articles of 2020 to see what are the latest novel things which are there. So it's almost the same thing which has already been mentioned by the previous speaker. Also, if you're having blinds and curtains, you have to be careful. If you're having those heavy blinds, then I'll probably would have to remove them and have something very simple where it can be washed, where it can be maintained very easily. Okay. So when you're using povidone iodine, see that you are aware of the allergy to iodine. You need to ask the patient about all these things and follow the guidelines which are there. Okay. So using a good mouth mask, when the patient steps in, you have to inform the patient on the telephone only. You will not be entertained if he's not wearing a mouth mask. Okay. So from the door, he starts with the mouth mask on. He sees that he sanitizes with his hands. So see that something has at least 70% alcohol for COVID-19, at least a 70% containing alcohol product is needed when you're using. So this all has to be kept in mind when you're doing all the different procedures. So with that, I would like to conclude with this small video.
Dentistry is one of the most high-risk professions in relation to COVID-19. In the unlikely event of providing dental care during the outbreak, dental professionals must take necessary steps to protect themselves and the public. If adequate precautions are not taken, the dental office can potentially expose dental professionals and their patients to cross-contamination. To minimize risk, following COVID-19 specific recommendations based on scientific research are suggested: telescreening and triaging. Undertake initial screening via telephone to identify patients with suspected or possible COVID-19 infection and gauge the severity of the dental condition to make an informed clinical decision to either provide or defer treatment. Patient arrival and evaluation. Measure the patient's body temperature using a non-contact forehead thermometer or with cameras having infrared thermal sensors on arrival at the dental office. Patients who present with a fever of more than 38 degrees Celsius and or respiratory disease symptoms should have elective dental care deferred for at least 2 weeks. Patients should be seated in adherence to social distancing guidelines. They should be required to wear a surgical mask and follow proper respiratory hygiene, such as covering the mouth and nose with a tissue before coughing and sneezing and then discarding the tissue. Ask patients to complete a detailed medical history form, COVID-19 screening questionnaire, and an assessment of true emergency questionnaire. Based on the information provided, dentists should make a clinical decision whether to treat a patient or defer treatment based in line with issued guidelines. airborne infection isolation rooms. Patients with suspected or confirmed COVID-19 infection should not be treated in a routine dental practice setting. Instead, this subset of patients should only be treated in airborne infection isolation rooms. Disinfection of inanimate surfaces. SARS-CoV-2 can remain viable in aerosol and survive up to 3 days on inanimate surfaces at room temperature, with a greater preference for humid conditions. Therefore, dental staff should make sure to disinfect inanimate surfaces using chemicals approved for COVID-19 and maintain a dry environment to curb the spread of SARS-CoV-2. Personal protective equipment. Dental professionals should follow standard, contact, and airborne precautions, including the appropriate use of personal protective equipment and hand hygiene practice. They should follow the recommended sequence of putting on and removing personal protective equipment and adhere to guidelines for N95 respirator use and reuse. Pre-procedural mouth rinse. Previous studies have shown that SARS-CoV and MERS-CoV were highly susceptible to providone mouth rinse. Therefore, ask patients to do a pre-procedural mouth rinse with 0.2% providone iodine, as it might reduce the load of coronaviruses in saliva. Another alternative would be to use 0.5 to 1% hydrogen peroxide mouth rinse, as it has non-specific virucidal activity against coronaviruses. Rubber dam. Using a rubber dam will help minimize splatter generation. It may also be advantageous to place the rubber dam so that it covers the patient's nose. Saliva ejectors. A four-handed technique together with low or high volume saliva ejectors can reduce the production of droplets and aerosols. Imaging. Extraoral imaging such as panoramic radiology or cone beam computed tomographic imaging should be used to avoid gag or cough reflex that may occur with intraoral imaging. When intraoral imaging is mandated, sensors should be double barrier to prevent perforation and cross-contamination. Instruments. To reduce the risk of generating contaminated aerosols, dental professionals should minimize the use of ultrasonic instruments, high-speed handpieces, and three-way syringes to reduce the risk of generating contaminated aerosols. Saliva is a major source of SARS-CoV-2, particularly in asymptomatic patients. Therefore, dentists should use of single-use instruments such as probes, mouth mirrors, syringes, etc. They reduce the risk of cross-infection and are more cost-effective when hidden costs of reusable instruments are considered. Secure Inject is a single-use safety syringe for dental anesthesia. It has received multiple awards for its innovative design to prevent cross-infections and needle stick injuries. In the event of treating high-risk COVID-19 patients, it is highly recommended that dentists use Secure Inject syringes. For further information about Secure Inject syringes, visit www.forsa-healthcare.com. Think safety. Think Secure Inject.
So with that, I would like to say a big thank you to APADENTO for giving me this opportunity, and thank you participants. And we can take some questions. And I would also like to invite you for the 4th International Conference by APADENTO, which is supposed to be happening in Malaysia from 10th and 11th of March 2022. Thank you very much.
Thank you, sir, for your informative session. So I would like to welcome our next speaker, Dr. Tarulata, who is a professor and head of Itakarani Dental College and Hospital, India. Please do say hi. Can everyone see the screen? Is the screen is visible? Thank you, ma'am, for your wonderful presentation. Now I would like to invite our next speaker, Dr. Hardeek Patel, CEO and founder of NG Smiles Dental Clinic, New York. So I'll be sharing the video on behalf of him.
I'm also founder of Institute, who courses hands-on. My name is Hardeek Patel. I'm going to be presenting predictable protocols for full arch dentistry. I am founder of Institute, graduated from NYU 2005, and I've been practice in New Jersey since 2005. I'm also founder of Institute, who courses hands-on in Mexico and Australia. Litmus techniques are in all Americans. So why do we use litmus techniques? Because we need to make sure that the treatment is more predictable, less chair time, more profitable, less disruption to the patient, and future-proof. Treatment planning. It's often called skillful planning is not detail. So this is the most important part of treatment planning. Any restoration, any full arch restoration. You measure twice, you drill once. Keep it simple. Too many complex protocols will make things pretty difficult. Patient practical choices needs to be considered because patient might not want one thing or the other, and they may not be able to get something they want. So it's important to discuss all the phase those treatment plans. That can be only one diagnosis, but many different plans. So depending on what data shows and what the patient needs are, you can select the plan that's more appropriate for the patient. Of course. So we take full arch control scanning records with the appreciative or Bennete or iTero. We take pictures, we glimpse at pores, full on periapical, concave CT scan, color scans, and we send them to design center, which is called visual smile design. And we do the backstop, we do a mock-up, we do the evaluation, and we select appropriate position for the teeth for the restoration. We also use digital face phone to record the jaw movements. So we import the data that you see from the Facebook to the providing software to manipulate the mandibular movements. Once you have all the data, then you decide which way is the right way, this way, that way, or another way. You have to decide when to next the incisor is for this patient, where your lip line is. If the lip line is too high and not show the teeth at all, then you place a longer incisor. If it's too much show, there's a lot of cut showing, then you have to reduce the ridge by a appropriate amount or move the incisor more ethically to hide the coming smile. If the patient is happy with the way the smile looks, no change is required in terms of moving the incisor position. Sometimes the patients are embarrassed when they come to the office and they give you a false smile. Like what you see here, this patient was giving me a smile, which was half a smile. Look at the original smile as this patient gave social media proofs. That's the lip lead support. But this is a very important question right here. So if you're going to do a full arch restoration, if there's no lip support, as you can see that with the advanced bone loss in maxillary mandible is in a classic position. If you do not restore the upper arch and open the vertical properly, you're going to have the middle of the face is something. It's very important to have a profile photo with the denture or without the denture to see what's more appropriate restoration. Full arch treatment options. There are basically three, which is fixed restorations, which is called FP1, where you have a teeth and no gum showing. FP2, which is the long teeth and you have a little bit of gum showing. FP3 is where you have to restore the artificial gingiva by adding a pink porcelain to the patients. What is going to be the interim restoration for this patient? So is it going to be a denture? Is it going to be imploding? Is it going to be teeth supported gradually through segmentation implants? You would, put some implants in, you would keep some teeth, and you would cut those teeth for the temporary bridge, and that will give during restoration while the implants are healing and being also integrated. And temporary implants to support interim restoration is another great option. Place 2 or 3 implants or arch to support the restoration without putting any pressure on the ridge. What material is it for cosmetic appliance? So is it going to be a full contour zirconia? Is it going to be metal bonded acrylic? Depends on what the final material is going to be. You would have to clear an appropriate room for prosthetic part. So full contour zirconia depends on what company brand zirconia it is. You would be about 12 to 15 millimeters from the side of the edge to the top of the cut. If this is less than that, you have a chance of cracking the zirconia. If it's a metal bar with acrylic requires a lot more bulk. You will need 50 to 70 millimeters from the incisal edge to the platform. Are you going to do this bone reduction or not? So if the incisor position needs to be moved apically, then you would have to do the bone reduction to get the movement of the incisor. Then you do not have to reduce anything except you have to make sure that you have enough prosthetic space for restoration. How many implants we're going to place? So it's going to be dependent on available bone, what type of arch the patient is, what is the patient age, habits, if they have a parafunctional habit or not. If they're parafunctional, then you need to have more implants to support the restoration. If they have a square arch, then they need to have more implants so that you proper AP spread can be achieved. Typically for maxillary arch, 6 to 8 10 implants. Doing arch 4 to 6 to 8 implants is customary. Do I need to tilt the distal implant or not? So if there is enough bone volume available for straight implant placement, excellent placement, posterior region, and you do not have to tilt those implants. But if there's not enough bone, especially in the mandible, where there's mandible is superficial, then you would have to tilt those implants to get AP spread. You have a proper restoration of the first molar area. What height of MUAs? So multi-unit abutments will sit on top of the platform on the implant, and most of the MUAs are 2 to 3 millimeter high. This platform needs to be sticking out of the gingival tissue about 1 millimeter higher than the marginal tissue, so that you do not disturb the connection of the tissue to the angle. What angles for MUA? So typically, I don't like placing any 17-degree or 30-degree MUAs in the anterior region. And as you can see, because of the anatomy of those MUAs, you tend to have this lip that shows up when the patient smiles. If the patient has very, very high lip line, if you're not going to give them FP3, and if you're just going to give FP1, if you're going to have to place this angled MUAs at 17 and 30 and 45, higher the angle, more color this metal showing through. It would be inside. So typically, anterior, you place much more palatal, so you can use 0-degree MUA. For canine, you can get a palatal placement with 0 or 17 degrees, but minimum height is about 3 millimeters for 17-degree MUA. So when you place your implant, you have to place your implant that deep, so only 1 millimeter of that height so that comes out of the tissue, so you do not see this metal bone. Posteriorly, it can be 17, 30, 45, depends on how you angle the implant posteriorly. Minimum height for 30 degrees is about 3.5. So again, you have to remember when you place the implant needs to be placed deeper to accommodate that extra height of the multi-components. Surgery. So once you have all the pieces together, you create a surgical guide based on the data that you receive from each of the scans, the photos, and the code scan. We make this guide in the office, 3D printer, it takes about an hour. Why fully guided? Because it will give you precise placements, depth control, and a safe, especially in the area where there's a nerve damage problem that will be avoided. Once you place the implants, once you place the MUA, we use something called photogrammetry unit, which is basically an camera that captures the image from outside of the oral cavity. We do not take any impressions. This will take about 30 seconds for the scan, and it will give you the depth and the position of the implants relative to each other. No verification jig is needed for any implant positions, no impressions needed. Can go straight to definitive restoration or have to get interim restoration. We do not have to do any conversions to this, so there's no, you do not need to make a denture prior. Let's take a look at this. Now this is the camera. This is the camera that shows the green light and that captures the domino right here. That's sitting on top of the multi-unit right now. And you hold this camera about 2 feet away from the patient's mouth. You go through all the data that gets registered on a computer like that. So once you have all the data captured, it takes about 30 minutes. You will receive a file that has can export to the Exocad or 3Shape or any design software for restorations. So you merge the pre-op data to the post-op high-macro scan. The left echo design restoration takes about 15 to 20 minutes, and the left echo will send to the 3D printer or a milling unit to enable temporary restoration. So we use 3D printer. This is something which is very portable printer. This is emission forms, very accurate. It takes about 30 to 45 minutes. Finishing time is about 5 to 10 minutes for storing of the resin. We can give the patient the same technique for you without any conversions. No full efforts required prior to the appointment. The resin, the material is 55 to 60% ceramic, nano-ceramic, the resin filler. So it's a very extremely strong material. It's a lot stronger than traditional denture material. You can polish it like porcelain. This is a printed restoration that you can see. It's nice and shiny after finishing. So this patient came into our office. The critical lapses everywhere. It's not happy to smile. Next to teeth for the periodontal disease. We took all the records. We did all the surgery. We used EMG, electromyograph, to record the vector and the temporal muscle forces to see the balance between the two sides. And then the second restoration accordingly. We did the occlusal scan inside the mouth with the T-scan. So we use T-scan.
So what is T-scan digital occlusal technology? Most dental practices around the world are using articulating paper to check occlusion. So naturally, your first instinct may be to think of T-scan as a form of digital articulating paper, right? Well, not exactly. Yes, T-scan has the ability to provide a snapshot of your patient's bite force and locations at MIP, but there's so much more to T-scan that T-scan can show you that you can't see any other way. Here's one way to picture it. Occlusion is a lot like an anatomy. Everything appears simple on the surface, much like you see with articulating paper. But below the surface is a network of tunnels that tells a much more complex story. A story that only T-scan can capture. In simplest terms, T-scan provides a digital movie of your patient's occlusion and accomplishes this in 3 ways. First, T-scan allows you to see a complete timeline of your patient's occlusion, from beginning, middle, to end. Secondly, T-scan allows you to see the function of your patient's bite, giving you the ability to analyze lateral movement, intrusive movement, chewing, as well as other dynamics. Third, T-scan is an excellent patient communication tool, applying visual, easy to understand data on their bite that will help build their trust in you.
So once we have all the data, here, we adjust the orally
Your treatment plan.
And this is less than 24 hours from the initial consult to surgery and utilization. No models, no impressions, no impression whatsoever. And as you can see, the patient is a beautiful smile. This is a temporary restoration that will be converted to a full contact recording actual restoration in about 3 months. But this is what you can do to use technology. Reduce the chair time, reduce the appointments. It took me 3 visits to get to this final temporalization, which is extremely important for the patients that were short on time or they are coming from far. It's also beneficial for dentists to have less time required to execute a given treatment. Any questions, please feel free to reach out to me or my email is Fernand, WhatsApp number 732-236-2633. You can also reach out as free if I'm missing. Thank you.
Thank you, sir, for your wonderful video presentation. So, any questions can be asked in the chat box. Now, I would like to welcome our next speaker, Dr. Arpat Shikari, Associate Professor, Department of Orthodontics and Crown and Bridge, Bogia Dental College and Hospital, India.
A very good morning to one and all. At the outset, I would like to thank the organizers for giving me such a great opportunity for today being the keynote speaker of this session. Well, I would be taking around 25 minutes to complete my presentation, and it's a big topic on COVID-19, so I tried to cover each and every aspect of the same. And well, it's a great privilege and pleasure to be present before you amongst the far acclaimed speakers of the today's session. So wishing all the very best to the organizers and the speakers. I'm Dr. Hardeek, currently working as associate professor and postgraduate teacher in the Department of Prosthodontics in Bogia Dental College and Hospital, that's in Patel, Himachal Pradesh. And we always have a ritual. So namaste to one and all, to greetings to my very dear friends in profession. And let me start with my presentation, seeking blessings from God. Let me move down the memory lane into the flashback. 100 years back, we were talking about the pandemic. The pandemics have been coming, and it was in 1918 when we are talking about the Spanish flu, which was there for around 2 years and caused a lot of devastation. So all went well as far as the 2019 year is concerned, but it was in the dawn of the year 2020, which led to a devastational pandemic known as coronavirus or COVID-19. So my topic for today is COVID-19, the implication in prosthodontic practice. I have tried to cover each and every aspect of COVID-19, the clinical protocols, the regulations, guidelines, each and everything. But truly, I would be taking more so the prosthodontic recommendations, how to practice it in the dental clinics or clinics and elsewhere. So, coronavirus disease is, we also call it with a number of names. I'm not going into details. We already know it had a high contagion, highly recombinant. It's definitely a virus, mystical or mysterious virus. So if I talk about today's scenario, yes, we had been talking about the first wave, we had been talking about the second wave, and there were, confusing guidelines about the third wave, whether it will come, whether it will not come, or it will just, will be just like a common cold virus. So this is how, today's scenario is again, I would say the curve is relatively going down and flat, but definitely not to take this as a casual approach. We as dental surgeons have to be quite cautious about the same, which I would be taking like subsequent scenes. So we all know, COVID-19 specifically has spikes, or it definitely invades, and particularly has a predominance for the ACE2 receptors. So the ACE2 receptors are present everywhere, and wherever spike proteins have the predominance, it makes a tight attachment with the human cell. This is how it, traverses and further infects the human. So we as, again, dental surgeons are the frontline workers. We always say that we, we are the first ones, and we have to be quite cautious as practitioners. So, routes of transmission, so many routes of transmission are involved, and particularly coughing, sneezing, as we talk about, or the aerosol transmissions, again, which is affecting the practices in a big way, which I'll be taking up again in the subsequent slides. So I would say it's a havoc that has really paralyzed the globe, across the globe. If you see the stats, but till today, India is on the number 2, US number 1. So that is how we have to be really alert, cautious, vigilant from the coronavirus, the COVID-19, when we are practicing dentistry. So as you know, COVID is not only has only the other domains of the profession, but it has really impacted the dental practices or the dentistry as a profession in a big way. So it had been quite devastating. It had been catastrophic. So we always follow there, and then some things are good also. So we started practicing the ritual namaste rather than the handshakes conventionally, and social distancing protocols, as we say, low risky duty, that is again very important. 6 feet distance, again very, very important. Tough etiquettes, yes, the best part is whenever sneezing or coughing, keeping the elbow and hand over it. So that's again the best part, that is we are protecting ourselves and the community as a responsible citizen. So what would be the action? Let us be more strategical when we are talking about the COVID-19. We all know the devastation being caused by COVID-19. So I'm gonna take the measures, the preventive measures, what all strategies we can plan as a dental surgeon. So we always say, that has been the best part, screening the patient. So what we have learned from amid the COVID-19 outbreak, that history, diagnosis, treatment planning has been given due consideration. Many of the times and many of the colleagues were like, okay, this doesn't hold much importance. So now, we are quite cautious. We are, talking about the informed consent. We are talking about or taking the documentation, the travel history, the history of the patient, about the fever and other symptoms. So every patient, Center of Disease Control, CDC, always say, taking active history of the patient, history about the symptoms, and you treat every patient like a COVID patient. So this is how you have to be quite cautious from inside, that yes, I have to deal in with the patients, and definitely have to screen the patients there and then, so that I can move ahead again with a great degree of caution. So the best part, which is still, I urge every dental surgeon, my friends, my colleagues, to go in for the telecommunication model, that is known as a tele-screening. We are in the, to converse with one another. So we have lots of modes like this to communicate with the patient, with our near and dear ones. So the best part, which I am also following in my practice, is the tele-screening. So telecommunication, that's again very important. Many of the times, geriatric patients or older patients in the practice, they are unable to come. So I just give them a call, or they can just call me, so vice versa. And there have been other modalities, so that if they have any problem associated, not only I'm talking about prosthodontics, but in general also, if they are encountering any particular problem, that can be covered there and then. So they, that ways I'm counseling my patients there and then. Although I know dentistry is not only based on the soft skills, you have to be good in communication of soft skills, but apart from that, you have to be really good when you are talking about the hard skills. So probably if if you feel your patient is quite happy with your soft skills and the treatment is not under the emergency, you can 50% of the patient is already cured. So the way you are speaking, this is how my teachers used to say, the way you are communicating with your patient, you should have such a healing talks where your patient gets cured there. So social media has, played a big role, a pivotal role in, in the same, in screening the patients. I have been again in touch with the patients. Many of the patients are quite in touch through WhatsApp, video calls, Facebooks and LinkedIn, other social medias. And this has really, impacted them in a big way. Through the video calls, we are doing the consultations, so what's video consultations, and even till today, even some of my patients who are fearful that no, COVID hasn't gone away. Please help us out. So again, that would be a good chance or good areas or arenas to help your patients. So awareness posters, this is again, we are using in our operatories and even in my own clinical practices, so that even the patient is still aware that what all guidelines I have to follow. Because me as a responsible citizen, I have to make sure that I don't cross-contaminate the other patients and even the doctors or the assistants in the operatory. So always remember, categorization of dental treatment, it's not only, I would say that as prosthodontics, not much about the emergency. But I would say that if your patient is not able to eat food properly, even that is an emergency. Now, generally we say, in the books it's written that, okay, it's totally pertaining to some medical thing. The emergency is particularly pertaining to the medical thing. It's not like that. It's generally, whenever patient feels slightest of this problem with the dentures or with other kind of prosthesis, this can also be, taken into the emergency, and the other treatment options being urgency. So probably we prioritize the patient, and we definitely triage the patient. So we prioritize in a way that we are treating the emergency and then the urgency, which can be deferred for some point of time. So, we have been talking so much about the personal protective equipments, PPEs, not going into details of the donning and doffing. This is the disposable gowns and the gowns we had been, using in the earlier times and still using. If not the PPEs we are using, and if we suspect any patient, yes, we are using the personal protective equipment properly for a particular patient, level 1, level 2, level 3. That all depends on the severity of the COVID-19, or if we suspect any patient to have this pandemic. So probably the gowns for every patient, the face mask, yes, not only during the clinical practices, but as a responsible citizen also always wear face mask, friends. I would tell you, and definitely I'm not saying you go in for such a kind of mask or go in for $9.99, $9.95. It's totally your choice, but at least if you wear a mask, definitely, it filters particles greater to a greater size. So definitely it prevents you from not only from COVID-19, from the other respiratory issues. So it's very important wearing protective eyewear again, but there are issues with the fogging. So try to use wherever possible the face shields. We are not exactly these days we are not wearing, and only in the suspected cases we have just categorized the patients and wearing them, because when you are wearing PPE for every patient, that is an honest opinion when you are wearing it, so you feel more claustrophobic. So it's a very closed kind of appearance, and it's more of hypercapnia and hypoxia. So hypoxemia, and that is how you feel you have a very blurred thing going on inside your mind. So gloves, wherever possible, latex gloves. Anybody having issues with the latex allergies, plunge into the vinyl or the nitrile gloves. The hand hygiene practices, again, friends, that's very important, because if you are following proper techniques for hand washing for at least 1 minute, if you keep washing properly, I think there would be no issues at all. And don't totally depend on the hand gloves. So generally we say, okay, I'll just apply a sanitizer and I'm now totally safe. No COVID can affect me. That's not the case. It's the technique of hand washing, using suitable, even if you use soap, but the technique is good. That's the best part. So I'm not going into the technique, how to use it. I'm sure everybody is well aware of. The hand rubs have to be used wherever required, not too much, because they are the alcoholic hand rubs and there can be a couple of skin issues. So try to use it for a minute period of 20 to 30 seconds. The shoe covers, this is a very good practice of removing shoes. When particularly in the down south, it's a good ritual. Respect to that particular ritual because you are carrying, a lot of infection from your shoes inside the house. So this is again the same thing which we generally follow. We have been following to remove the shoes outside the dental clinic, and wherever possible, try to use the overhead shoe covers or the shoe covers, or this is the shoe dispenser which we have in the operatory. The overhead caps, head caps, again a very important part of the PPE. So thermal screening had been a very good modality for mass screening, but thermal screening which we are still doing, we have a thermal scanner which we are doing, not very accurate, I would say, again an honest opinion. So what we do is we have a pulse oximeter available with us, which gives us a very good idea about the oxygen saturation, that is the SpO2 levels. So when we feel the SpO2 levels are slightly below or at the borderline, we suspect that maybe the patient, although we can't say definitely before any scans or chest CBCT or something like that. So before that we can't say, or we always, maybe we suspect of yours. So we then become more cautious. So this is not exactly to classify a patient that he or she might be definitely having a COVID-19. It's not like that. It's just to, make you aware or alert that yes, patient may have such problem, and then we go ahead further. So the waiting area, again, this has been again practiced in my hospital. So we follow a social distancing protocols in the operatories, in the practices, try to follow it, and even in these times. So aerosols have been, as a dental surgeon, so aerosols are very small particles and less than 5 micrometer. Due to buoyant forces, they are suspended in air, and it has been said that around 8 to 12 hours, that is half a day, they remain suspended. So anybody coming inside the operatory or wherever you are using the aerosols, they tend to contaminate and cross-contaminate the other people in the operatory. So friends, be very aware and alert when you are talking about the aerosols, because they are inevitable in the dental practices. So not only in dental and prosthodontics, wherever you are using our equipment and is such that aerosols are bound to occur. So we have to, be more conservative, and we need to follow practices, or we need to curb the spread of aerosols so that it doesn't contaminate the individuals operated. So not completely, I would say that say no to rotary rather. So rotary instruments have been really helping us a lot, but then even in these devastational times, because of the spread of the aerosols, they have been, causing a lot of damage. So, WHO, World Health Organization, had been saying that the COVID-19 is, the contact is through, or the transmission is through this surface. But later, the guidelines have been so confusing. Later they say that it is a totally airborne virus. So if it is airborne, we need to be more cautious. And that, yes, that is true, because the aerosols can cause a lot of devastation. It can contaminate in a big way. So in your operatory, you have to work with vigilance, and probably try to use hand instrumentation wherever possible. So this is how there has been a paradigm shift from the rotary to the hand instrumentation, using rubber dams wherever possible. Try to isolate so that there is less salivary secretions and the aerosolic transmissions are reduced in the operatory. Radiographic examination, when we use the intraoral radiographs or the sensors, the patient, it may induce gagging in the patient and can lead to more splatters in the environment. So try to use extraoral, and this is how, now we understand the significance of the extraoral radiography. Don't use any sensor inside, you use CBCT scan, or you can use a biting radiography. So this way, the patient would be more comfortable, and definitely you get a better diagnostic picture of the particular area to be treated. A four-headed dentist, we always say 1 and 1 makes 11. So that is the thing. When the number of assistants or the number of or your team, you have a very good team. So this improves the efficacy of your treatment, and even your patient feels more comfortable. So try to practice a 4 or a rather a six-handed dentistry. High vacuum suction, they are of a big help because they tend to help in the suction of any saliva, blood, other kind of secretions. And we have been talking about the micromotor because they don't cause much aerosols into the outside environment. So wherever possible, what you can do is when you are doing a tooth preparation, so you can use a micromotor. It would take a lot of time, I can understand. So a better innovation to the air rotor is the electric micromotor, which has a better torque or a rotatory speed, which is very high, nearly equivalent to the air rotors. But the only thing is that you're doing it in a drying fashion, so it may cause a lot of damage to the tooth and subsequently the pulp. So always, that is why I told you use a 4 or a 6-handed dentistry. So ask anybody to just irrigate that particular area in between so that the cooling effect to the pulp remains. So hand basins are also designed with the anti-retraction one. So that is a one valve retraction. That means there would be no backflow of the saliva, blood, the water, the secretions. It would go in a single direction. So that is the purpose of the anti-retraction valve, which prevents the backflow of all these contaminants. So operatory preparation, they have been scheduling the appointments in a way so that there should be proper time between the two patients. So always make sure using appropriate sanitizers or disinfecting solutions. They have to be clean. The chair side, all the necessary accessories have to be properly clean. This is what we have been doing, but now we became extra cautious amid the COVID-19 outbreak. The well ventilation in the clinic, again, very important because any kind of aerosol, you can't say a zero aerosol. This can't happen, and this is really not possible. So every time when you have the aerosolic transmissions in your own respective, OPDs or your operatory, so that becomes again very important. So this is how the exhaust fans or negative pressure rooms. In the summer months we were trying. Although it is very difficult, but we were trying to switch off the AC air conditioners because they cause a positive pressure room and there is no way of ventilation. So always try to have a well ventilation. Pre-procedural mouth rings, very important. Always, whenever a patient is coming to you, ask the patient to go in for a pre-procedural mouth rinse using suitable, rinse solutions and other solutions. And particularly, I have been preferring the povidone iodine, that is the betadine, in a percentage of 1%, which is used, which further avoids or reduces one, the aerosol transmission, second, reduces salivary secretions, and thirdly, the main thing is it is trying to reduce the viral load inside the oral cavity. So HEPA filters, again, they have been helping the dental practitioners in a big way because they have the capacity to reduce the filters up to 99.97%. So this is how it's the good filter capacity of HEPA filters. Many of my friends have been using air purifiers in their own OPDs. UV light, some of them have been using, but it's good equipment to be taken care of. The negative ion generators, yes, the anions, they help to again reduce the pandemic in a big way. The EcoShield, that is a fumigator, and when we are doing fumigation, and so that and fogging, fumigation and fogging have been a very good choice of the disinfection modalities. When you are trying to close the clinic, and better is you get it done at the end of the day. So at the end of the day, that's the best part when you are fumigating and fogging your clinics. So the very next day you open. So it's a good thing if you have very well ventilated. All these things, a couple of whatever best you can incorporate in your own clinical practice, that would be the best part. So let me move particularly, this was what I was talking about, the general recommendations into our clinical practices. So if you are practicing as a general dental practitioner, you have to make sure that all these, guidance following the government and the other regulatory bodies. Again, that's very important. But when we are talking about the Department of Prosthodontics, so specific recommendations are needed. So, we very well take care, particularly we are dealing with the old people, the geriatric individuals. So they have to be counseled. As I told you about the tele-dentistry model, this is how we have to, take care in a big way. Because psychologically, then during this point of time, they have been becoming more weaker. They think that, I am maybe getting COVID, or I may get at one point of time. So this is how, mentally they have to be, or psychologically they have to be counseled in a good way. So using, whenever diagnosing, using the disposable diagnostic set can be a good option when the patient is there on the chair, you are taking history, and probably you can use this set. As I told you about the external radiography, always try to prefer the orthopentomogram or panoramic radiography. More so, if you want a clear picture, you can go ahead with the CBC, bone being included tomography. That's how we go about it whenever we feel the patient is coming for any endo, or particularly as I'm talking about prostate. So implantology, you try to prefer the sectional CBC. So urgency, I will say that not only urgency, if patient is feeling even a single speck of issues with the denture, with fixed prosthodontics, patient is not able to eat food. So that becomes a big emergency, not exactly the emergency in prosthodontics. So sometimes it can be sensitivity of the vital tooth. When the tooth has been prepared, it is a vital appointment, and prosthesis has been given. So sometimes patients say that I am feeling, doc, I am feeling hot, cold, all those sensations, sensitivity due to eating sweets or eating lime, something like that. So, but bent screw loosening, as far as the implantology is concerned, the broken dentures, as we can say, fracture of the dentures, they particularly require repair during this point of time. So, broken dentures, patient will not be able to eat or chew food. Any peri-implant infections, any superficial infections may definitely be an alarming situation for us. So, the guidelines are not only for the dental surgeon, it's for the patient, the assistants, the laboratory guys. So it's a teamwork which I'll be showing you. Definitely it's for every one of us. So during this time, we have been moving from the analog, that is the conventional impressions we have been using, to the digital time. So if you had a provision of digital impressions, intraoral scans, or the extraoral scanners, that's the best part, because then you are not wasting so much of material. There is no physical impressions, no need to use the conventional based ways, and no need to all those advantages of the digital impressions over the conventional based impressions, they creep in. So obviously the best part is you have to just scan the patient's impression inside of the oral cavity, and this is sent as a file, as the STL OBG file to the laboratory guy. But then you need to have a very good lab support. You can't say you have a intraoral scanner and then probably the lab support is not good. So this way it won't help you out much. So best part is incorporation. So there has been a lot of significance and definitely a good, great paradigm shift from the analog to the digital times. So all these, we have been reading the impressions. If you don't have provision of the digital impressions, we have been talking about the conventional impressions, which we are making. So we are using suitable trays. Always remember to disinfect the impressions, disinfect the trays. Although we try, to auto-click these stock trays whenever we are using the patient's mouth. So disinfection has been going on, previously before the COVID came. But yes, now again, I said, as I repeatedly say, we are again taking it as a cautionary measure. We are repeatedly doing it, disinfecting the impressions, making sure that doesn't distort the impression materials. So removable prosthetics, patient may be coming, or patient may be talking about, as I said, broken dentures, fracture of the dentures. So the same has to be repaired. So make sure you teleconsult the patient, what kind of denture is it, okay, what is the level of fracture, all those things. And then you can probably call your patient, disinfect the denture, try to repair it, because if the patient is not able to eat food, somewhere around, it's our fault. So as a responsible prosthodontist, we have to make sure that we send the patient back, and the patient should be very happy eating food. Again, tell your patient to send the picture or something like a selfie to you if he or she is happy with the new set of repaired dentures. So patient generally always say about the ulceration. So always, the patient is not able to come to you, you can at least prescribe some kind of gel or anesthetic gel to your patient, so that, and even try to tell the patient the technique, how to use. So if you are doing that, many of the times I have been doing WhatsApp video consultation, telling my patients, that how to apply the gel, what all areas, where is the ulceration, please show me. So all those things, that has really, the social media has really eased out our life in a big way. The fixed prosthodontics, as I've told you, we are using air rotors, so rotary instrumentation and aerosols. So issues with the aerosols have been taken up and they have to be dealt with in a good way, in a more professional way. So any fractured processes, tooth preparation generally we avoid it, but now we are doing it with great caution using all the PPE model and removal of the fractured processes in case patient feels that okay, my fixed processes has been debonded. So in that point of time, yes, the processes has to be first disinfected and then probably it has to be cemented in a proper position. So wherever possible, if you can't make impressions or immediately if you can't give the processes to the patient, what we were doing is we were placing the temporary crowns or we were giving a provisional crowns to the patient. So there and then you have to decide, you have to be, very cautious and that point of time you have to just decide, you have to take the final decision what I have to do at that point of time. Placement of the implant, much of the times only simplicity or any particular, the main emergency was if the previous implant has been done and there is some point of emergency or there is some point of peri-implantitis and infection which is really causing a lot of discomfort to the patient. At that point of time we have been doing it, but again cautious. But this point of time, today's scenario, if you ask me, yes, we have been doing with the full COVID appropriate behavior and probably we have been doing all sorts of practicing rather every subsection of the prosthodontics using all the available modalities. So maxillofacial, again, patients have been coming with the, for the treatment of the obturators. And yes, we have been doing prosthetically rehabilitating the patients wherever we feel the area has been an area of either a congenital or acquired defect. So we have been practicing all the modalities for them. The lab protocol, again, it's not only about the clinician, it's also about the laboratory person. So, it's a one-on-one, I said 1 and 1 makes 11. So it's how you have to be responsible and you have to, tell the lab guys to be very vigilant when we are, if you are sending the impressions to the lab for further lab. So they also have to, further disinfect and before doing anything, they should also ideally use the PPE model if possible. Telecommunication again going on. So if you have a good coordination with your lab, if your lab guys are, doing it or following stringent protocols. So, you have to really tell them in a big way that how it is important to practice the cross-contamination and prevention of the cross-contamination, because sending impressions to the lab can be a source of big cross-contamination. So always, guide your laboratory technicians and, this is how we work as a team where we say together everyone achieves more. So this is how, the best part is you would give the best or the best processes to your patient, which not only depends on you, but depends as how a team is formed and how your lab guys are proficient. So oral hygiene instructions, this is again very important because if the patient is not able to understand there, you can send it through WhatsApp or you can again probably explain your patients through the telescreen model. So let me just conclude the session with certain take-home messages that there have been so many pandemics coming in dentistry, and we have been, always at the forefront as a fighter. So be a fighter. We always say how to start. There were so many questions, occurring in the minds of everybody, how to start and what's the best time to start. So we, at some point of time, we had now learned to live with it. We are, talking about the new normal practice in dentistry, taking all suitable precautions. And PPEs, we are just, judiciously using wherever possible. As I told you, never ever exaggerate, be very strong. First, you have to be mentally strong. Only then you can re-age your patients in your field. So probably your teamwork is very important. It's always said a pinch of prevention is worth a pound of cure. So I feel many studies are still coming up and further research is still required so that we can prove the best of the best diagnostic and treatment protocols. So yes, friends, it's always a long way to go. And we are still doing the same, serving the society as a responsible citizen, as a responsible dental surgeon, as a responsible prosthodontist. So we never say, we are moving like a river. We never say, okay, I'll try to start. I'll see. Right now, that's the best time, even if you haven't incorporated some of these sources. So some of my publication, this was a publication, in one of my international journals, how turning calamity.
Thank you, sir, for your informative and wonderful presentation. So I would like to thank all the keynote speakers and the audience who were attending, and the organizers, APADENTO and BioLeagues Worldwide, for organizing such an informative webinar on dental field. And the certificates of all the presenters will be emailed you so that you can download your certificate using the link. So thank you very much.